So for pulmonary opacities showing airspace nodules, no, your typical example of your Bat's wing or your pulmonary edema here on your X-ray and here on your CT scan. You can see that there is haziness, there are confluent airspace opacities with linear um, densities emanating from the hilar area, producing a butterfly or bat's wing appearance, which is very typical of your um, pulmonary edema because of renal pathology. But for pulmonary edema caused by a cardiac problem, you expect the heart to be enlarged, no? So here you have the ground glass densities in the inner to mid-lung zones on the chest, on the CT scan of the chest, which is representative of your pulmonary edema. So another example of your pulmonary opacity resulting from atelectasis, no? You have here homogeneous opacification of your left lung, and also here on CT scan you have homogeneous opacification here on the left side. And how do we know that this is atelectasis? And how do we differentiate it from atelectasis, from consolidation or pleural effusion, no? Especially if it's homogeneously filling up the hemithorax. You know that it is atelectasis because there is shift of the mediastinal structures into the area of the lesion, no? So you have ipsilateral mediastinal shift because atelectasis is volume loss. So here is an example also of atelectasis of lobe, the right upper lobe. You know that this is atelectasis because there is upward traction of your minor fissure. And here, because you have volume loss here on the left side, you can see that the right lung is herniating towards the left hemithorax. No? Because of volume loss, there will be compensatory emphysema in some cases. So, an example of interstitial densities, no? You have your linear densities here on your X-ray as exemplified by fibrosis, no? So those are linear densities in your chest X-ray due to fibrosis. So your interstitial densities may also be due to to pulmonary congestion. Sometimes you can see enlargement of the heart, and then you can see linear densities emanating from the hilum, or sometimes you have transverse linear densities here in the bases, no, due to your curly lines. So as you read your book, you will learn about it. So much with the pulmonary densities. We now have pulmonary um, lucencies. Your pulmonary lucencies may be focal, it may be a unilateral hyperlucency or bilateral hyperlucency. For your focal lucency, this is exemplified by your cavities, cysts, bullae, blebs, and bronchiectasis, and pneumatoceles. So your cavity, no? This is usually seen in tuberculosis. And your tuberculosis, when you see this in your patients with tuberculosis, it means that the tuberculosis is active, no? So we describe the cavity on X-ray as a thick-walled area of lucency. So you can see that the lucency is in the center, and this is surrounded by thick walls. Okay, so this is your cavity on X-ray and your cavity on CT scan. Your cavity can also be seen in large masses, no, with areas of necrosis. But with these cavities on new growths, you will see air fluid level, because if the area necroses, then there will be fluid or blood, and then it's also interspersed with air, so you will see air fluid level. Another entity that can produce this picture is your pulmonary abscess. Okay, your pulmonary abscess will show you thick-walled lucency with air fluid level, such like the cavity in your new growths. So what are bullae? No, bullae are thin-walled collection of air. So you see here an area of lucency, no, with no lung markings, and it is thin-walled, and it is within the lungs. So here on the X-ray, you will see it as an area of increased lucency, and then there is your increased density here because your lungs, your normal lung is being compressed. So bullae are larger than your blebs, no? So your blebs are smaller. They are usually about 2 millimeters, and they are seen along the periphery, no, of the lungs. So they are best seen on your CT scan, and it's difficult to differentiate it from your bronchiectasis. But your bronchiectasis, you have to read this on your book because you have different types of bronchiectasis. So they are also thin-walled lucencies. They may be rounded or they may be tubular, depending on the type of bronchiectasis, because sometimes they may be cylindrical. So to differentiate it from your cavity, your bullae, your blebs, and your bronchiectasis are thin-walled. Okay? Sometimes these structures may contain hemorrhage or um, exudates or um, sediments, so it may give you an air fluid level. Your pneumatocysts are complications of your pneumonia, specifically staphylococcal pneumonia, no? So they may be thin or thick-walled, and they may also contain fluid within, and they may produce the air fluid level. You know that it is a pneumatocyl because you have areas of parenchymal airspace opacities or consolidations together with your lucencies, plus your history of a patient who is febrile with multiple skin lesions due to staphylococcus infection. As I've said earlier, your pulmonary lucency may be unilateral, involving only one lung, no? Or it could be bilateral, as seen in this slide. You know that there is hyperaeration or increased lucency of the lung when the diaphragm is flattened. as seen in pulmonary emphysema. So your heart will also um, show a tubular configuration, and it will be smaller. So if you see a chest x-ray with hyperlucency of the lungs, flattened diaphragm, and a tubular um, configuration of the heart, then your diagnosis will be due to pulmonary emphysema. So this is how your pulmonary emphysema will look like in your CT scan. You see that it's almost black, not your gray lung. So another radiographic finding that you should not forget will be your mediastinal masses. I hope you have placed on your minds already the picture of a normal chest x-ray, so that when you see this picture, you already know that this is not normal. So you have lobulated density along the mediastinum, no? So you have mediastinal masses, and most often these pictures, this picture is due to enlarged lymph nodes. So your um, mass in the posterior mediastinum will show this picture on CT scan. It's the posterior mediastinum because it's already adjacent to um, it's posterior to the heart and adjacent to the spine. It's in the paravertebral area. So I hope you still remember that you have your anterior, your middle, and your posterior mediastinum. So you have these different locations, you have these different divisions, I mean, and each division contains specific structures, no? So like in the anterior mediastinum, you can have enlarged lymph nodes, no? And then another structure within the anterior mediastinum is your thymus gland. So you can also have thymoma. And then another lesion in the anterior mediastinum will be your teratoma because you have your soft tissues there. And then sometimes your thyroid gland will enlarge and go into the thorax, no? So you have thyroid mass going into the anterior mediastinum. So you have 3T's and 1L: thyroid, teratoma, thymoma, and lymphoma in the anterior mediastinum. While in the middle mediastinum, you have your heart and your vascular structures, and you can also have lymph nodes in that area, no? So expect aneurysms, no? Or enlarged lymph nodes in the middle mediastinum, or your heart masses, no? You can also produce heart masses. And then for the posterior mediastinum, it's mostly neurogenic tumors. So here is an example of your mediastinal mediastinal widening, no? Because of a gastrointestinal problem, which is your achalasia. I hope you have encountered that term already, achalasia, which is narrowing of the distal portion of the esophagus because of a neurologic problem with the innervation of the distal portion of the esophagus. So there is problem in emptying your esophagus. So as the time goes by, your esophagus enlarges and produces mediastinal widening, no? So you can see here the right heart shadow, and then there is a density, another density um, here in the area, and you don't see the gastric bubble. So this is a very typical example of your achalasia. I hope you will not forget this picture.